Welcome everyone to tonight's APSC CME webinar series, the MedMASTER program, focusing on the latest evidence for high bleeding risk PCI and renal denervation. The date stamp today is Friday, 18 March 2022, 7 p.m. Singapore time. This event is organized by the APSC, endorsed by the Singapore Cardiac Society PCI chapter, EBAC accredited for CME points in collaboration with Medtronic. I'm the host for today, the immediate past president for the APSC. And the format for today is going to be advisory board format. We're going to be more discussive. But to open us up, we have 3 teaser lectures to open the session. The first speaker will be Professor Keong, Deputy Medical Director at the National Heart Centre Singapore. He's going to speak to the Onyx 1-month DAPT program. How far have we come with the evidence? This will then be followed by Professor Nigel Jackson from the Prince of Wales Hospital, Clinical Director at the Eastern Heart Clinic, Australia. He's going to, in 10 minutes, also speak to us on how do we make sense of all these HPR trials that we've been bombarded with. Then we'll take a pause to discuss the HPR questions, and the closing lecture will be delivered by Professor Tang, Senior Consultant Cardiologist, the Director for the Coronary Intervention Service at the National Heart Centre Singapore. He's going to narrate to renal denervation, what does the evidence tell us in the year 2022. I would then like to introduce our whole series of key advisors for tonight. Dr. Keong is the head and senior consultant from Sarawak General Hospital from Malaysia. Professor Tan Hui Chim is a senior advisor at the National University Heart Centre Singapore. Professor Aaron Wong is the deputy Medical Director at the National Heart Centre Singapore. We have Christopher Khoo from NUHC, Professor John Yap from HCS, Dr. Goh Yu Seong from Changi General Hospital, Dr. Patrick Lim, the head at the Khoo Teck Puat Hospital, Dr. Fahim Jeffrey from Tan Tock Seng Hospital, Dr. Syed Imran from Khoo Teck Puat Hospital. We have Dr. William Cristando from Ng Teng Fong General Hospital, Dr. Paul Ong from Mount Elizabeth Novena Hospital, Dr. Dinesh Nair from Mount Elizabeth Orchard Hospital, and last but not least, our honorary Singaporean from Brunei, Dr. Raja Gopal from Gleneagles JPMC Brunei. Some disclaimers, the content is copyrighted by the APSC. The views and opinions expressed are those of the faculty and do not represent those of the APSC. This webinar is currently live streamed by Wonder, APSC Facebook and YouTube pages. CME points will then be submitted for those who are connected throughout the full duration. You will receive your certificate of attendance after completing a survey sent by email. For the participants dialing in, please click onto the Q&A boxes if you have any questions. I'll defer your questions to our esteemed panelists. A pitch for upcoming webinars on the 26th March. We have a very interesting session with women at the helm of a transcontinental chip case sharing session by Tess. 1st April, we have APSC Cath Lab workshop in Sengkang General Hospital focusing on PCI in diffuse diabetic patients. So let's get started for tonight's advisory session for MedMaster. I'd like to welcome Professor Keong to start off in the DAPT 1-month program. KK, please.
Thanks very much, Jack. I hope you can hear me well. So I was asked to talk about the Onyx 1-month DAPT program and how far have we come with the evidence. And obviously in 10 minutes, I can go only that fast and that far. So please bear with me as I go through the evidence. These are my disclosures. So I want to start off by talking about the current definitions of high bleeding risk in PCI trials. And obviously that is a story for a long session, but I want to highlight that the key point is that for high bleeding risk PCI trials, in general, you should have at least 4% of at least BUG3 or 5 bleeding over a 1-year period. And this slide just summarizes that for the Onyx studies, you have a very broad range of criteria enrolled for high bleeding risk. The Onyx study is unique in that it is an all-comers trial, and you can see from this slide that the Onyx 1 study included multiple subsets of patients that would otherwise have been excluded from other trials, which make this truly an all-comers trial. The BARC bleeding, rather definition for bleeding is important because it provides a common perspective as to what constitutes minor or major bleeding. And essentially, for our purpose, what really is important is major bleeding, which is type 3 and type 5. So the original Onyx 1 study was published back in 2020, and it is now 2022. So 2 years worth, what have we learned? I think it is worthwhile to talk about the Onyx 1 global study design. This is a randomized controlled trial, 84 global sites. And this is in comparison with the BioFreedom drug-coated stent, which at that time was the only stent with data on 1 month DAPT. And essentially, this is a high bleeding risk cohort with patients undergoing PCI, no lesion or vessel limitations, which I think is important. The primary safety endpoint is cardiac death, MI, or stent thrombosis, definite or probable at 1 year. And there is a secondary efficacy endpoint, which I think is shown on the slide here. 1,000 patients in each arm. And I want to quickly just highlight some of the key points of the baseline characteristics. You can see from this slide that it is a very broad group with close to 40% diabetics and patients with acute coronary syndrome, at least half, which gives to mind that this is really quite a broad group of all comers. I should also add that atrial fibrillation accounts for almost 1/3 of patients. So what are the key findings for a primary safety endpoint? No difference between the two groups for the Resolute Onyx and the BioFreedom group. And if you look at the primary safety endpoints and its components, no statistical difference between the groups for either cardiac death, MI, or stent thrombosis, MI, cardiac death, or stent thrombosis in isolation. But if you look at a 1 month landmark analysis, that is from the time the second antiplatelet agent is stopped, then there appears to be some signal of differences, and especially for MI, there appears to be a slight difference in favor of the Onyx stent. Be that as it may, the BARC bleeding rates, which is BARC 3 to 5, again, no difference, which is what is really important. And consistent with our understanding of a high bleeding risk trial, this is in excess of 4% for 1 year. What about the Onyx 1 CLEAR study? So what is the CLEAR study? So you remember that the Onyx 1 Global is a randomized controlled trial. The Onyx 1 CLEAR study is taking data from the Onyx Resolute arm and data from the single arm Resolute study from US and Japan, and looking at data. This is important because it gives, when we look at the sub-studies, there's a difference between the randomized trial and the cohort studies. Essentially, when you look at the Onyx 1 CLEAR program, the performance goals in terms of cardiac death and MI or BARC bleeding, 3 to 5 bleeding, appears to be very robust as well, meeting the for those patients who clear the 1 month definition. For patients with who are on this program, I reinforce the safety because at up to 2 years, you can see that the cardiac death MI rates, TLR or definite stent thrombosis remain very low. Again, highlighting the safety of this particular stent platform. So now we go to the sub-analysis, and there are so many sub-analysis that because of time constraints, we are just going to go into the specific subgroup. So this is for bifurcation. And I just want to highlight that the true bifurcations were seen in more than half of patients in the CLEAR study. And of these, slightly under half were ACS patients. You can see also that these patients also have a substantial calcification. And what are the results? For bifurcation versus no bifurcation, you have no difference in safety and efficacy in patients with bifurcation lesions despite the increased complexity. I highlight, of course, the fact that half of these patients had heavy calcium and had true bifurcations or were ACS patients. Now, this is the global trial, and this is not the cohort component. This is the ACS subset of the randomized trial. And again, for the ACS cohort, you can see that the breakdown is about half of them are non-STEMI with about 10% STEMIs. And again, in comparison with the BioFreedom platform, it does appear to have significantly lower MI rates with the Resolute Onyx platform. What about the AFib group? This is for the prospective cohort 1, Onyx 1 clear sub-analysis for AFib, and basically compared those with AFib without AFib, and about 530 in the AFib group and about 1,000 in the no AFib group. And you can see that no real difference between the two cohorts. There is more BAC2 bleeding, but for BAC 3 to 5, which is what is important, no difference in significant bleeding. Complex PCI sub-analysis, and I won't go through the details, but you can see it can range from more than 3 lesions treated, left main disease, chronic total occlusions, etc. And this is just to highlight that for B2 or C lesion class, about 80% in each group, and about half of patients with acute coronary syndromes, and also with significant calcification. Again, no real difference between the complex and a non-complex PCI group. Of course, numerically, there does appear to be slightly more numbers, but none of these were statistically significant. Having slightly more complex, having more events in the slightly more complex arm really is no surprise, but I'm reassured in terms of the fairly similar outcomes. Diabetic group, again, no differences in between the two groups. Again, because of diabetes, we do anticipate more complications over a period of time, but these differences were mild and did not amount to statistical significance despite the more complex diabetic patients. Now, this is the last sub-study which I'm going to show. This is just came out, I think, the CRT for small vessels, that is 2.5 millimeters or less. And this is about 1/3 of patients in the prospective cohort study, not the randomized trial component, the Onyx 1 sub-study. And you can see no difference despite small vessels. And again, this is reassuring for all of us. So I'd like to summarize that a high proportion of patients at high bleeding risk, at least for the small vessel disease, have similar outcomes compared to those who are not small vessels. The Onyx 1 platform has multiple sub-studies. I've just shown several of them, and there are more studies coming up in the meetings in this year. We have talked about the AFib cohort, ACS cohort, complex PCI cohort, diabetic cohort, bifurcation cohort. So all of these are reassuring. So to summarize, I think we all appreciate that, when we do PCI, that we are weighing the risks and benefits of major adverse cardiovascular events versus bleeding. And a shorter DAPT duration in general is better. And therefore, any stance or strategy with a shorter DAPT will be advantageous. The Onyx 1 study supports the safety and efficacy in high bleeding risk patients in all comers, which is really impressive. And that in the various sub-studies I've shown, its safety and efficacy has been confirmed. And we know that the Onyx 1 stent is the first CE-marked and FDA-approved stent for 1-month DAPT. And with that, I thank you very much for your kind attention. Thanks. Over to you, Jack.
Thanks, KK. Very comprehensive, very fast review of the very exhaustive series of Onyx 1 trial, I must say. So now we'll transit to Nigel first before our discussion to maybe help us understand how to make sense of all this multitude of high bleeding risk trials. So Nigel, please.
Thank you very much, Jack. And it's a privilege to be here with the group to present. So my task in 10 minutes is to discuss how do we make sense of a lot of trial data. Just backing off, high bleeding risk patients comprise a growing subgroup that we're seeing in the cath lab, possibly at least 40% in the real world setting. But despite the data, we really don't know what the optimal management is, because these patients are typically excluded or underrepresented in the trials. And it's the big theme that I'll keep coming back to, we lack a standardized definition of HBR in the trials that we've had to date, which limits interpretation across correlation. So really, the so-called all-comer trials, which provided the regulatory approval for the, globally for the second generation stents that we use in all of our cath labs, the Resolutes, the Xiences, the Synergies, and so forth, and the Zero, is really based on highly selected patient subgroups, which basically are only patients considered suitable for guideline recommended DAPT. So HBR patients haven't got into the so-called all-comer trials that based inventory of stents. But if you look at the history of trials in these sort of patients, there's randomized trials and there's registries that you've heard of. 2015 was a key time when the Leaders Free came out. And we moved on. We're going to talk about the ARC HBR consensus documents, which is very, very important. You've heard about Onyx 1, RCT. You can't see there on the right is MASTER DAPT. Duration of DAPT is largely 1 month, but it's variable. 3 months for some of the registries, up to 6 months. That's an issue. We've got a number of single-arm registries, particularly with our second-generation DES, looking at shorter DAPT times with the historical controls to validate. But more importantly, or as importantly, some of the trials are focusing on devices. One device as a Leaders Free, the bare metal stent versus the biofreedom stent, same stent used in Onyx 1 randomized trial. Alternatively, we've got high bleeding risk trials with a single device with variable DAPT duration. So we need to keep all this in mind. If we look at the randomized trial data, we know the Leaders Free, published 2015, showed superiority of drug-coated stent biofreedom at 1 year with 1 month of DAPT. Senior trial with over 75 years patients with a Synergy stent superior to BMS at 1 year, but with 1 month of DAPT, but it was 6 months if you had an ACS. So we've got heterogeneity. There's a drug balloon trial, which I'm not going to talk to in detail. You've heard about the Onyx 1 randomized trial. We've got ongoing trials. We look forward to this data, the COMPARE trials comparing two biodegradable polymer sirolimus-eluting stents, ultra-thin, with ESC guideline-directed DAPT. We have the BioFlow DAPT study comparing the Onyx stent, which you've heard about, with the Acero stent, with 1 month of DAPT. But if you look at the endpoints on the right-hand side, they're completely different. So we've got different DAPT durations, different primary endpoints. Moving to the MASTER DAPT trial, which was published, presented late last year. Important trial, over 5,000 high bleeding risk patients treated with UltiMaster stent, really with no restrictions on clinical presentation or PCI complexity, randomized to abbreviated DAPT or standard DAPT. There were 3 co-primary endpoints. The first was the net adverse clinical events, so death, MI, stroke, BARC 3 or 5 bleeding. And abbreviated DAPT was non-inferior to standard DAPT. And abbreviated DAPT, the median period DAPT 34 days versus 193 days median in the standard DAPT group. If you look at MACE, death, MI, stroke, non-inferiority again with abbreviated DAPT. And if we look at the bleeding endpoint, major or clinically relevant non-major bleeding, so that's BARC 2 and 3 or 5 bleeding, actually abbreviated DAPT is superior to standard duration of DAPT in terms of reduction of bleeding. So they're the randomized trials. If we look briefly at the single-arm registries, which are classically compared to historical control or an objective performance goals, if you heard with the Onyx Clear. There was a Leaders Free 2 registry, which was actually the biofreedom cohort in the US compared to the historical BMS group from Leaders Free 1. 1 month of DAPT, no surprising with the results. Evolve with Synergy, 3 months of DAPT, showed superior synergy of historical control groups. Similar data with an UltiMaster study in the US, 1 month of DAPT, and the Onyx Clear composite group you've heard of. We also have registries with Xience 90 days compared to Xience historically 12 months. Xience 28 days compared to historical control of 3 months. These have got even more, some intricacies of enrollment, which I don't have time to go into, which introduce more heterogeneity. So I hope I've shown that there are a plethora of studies, but there are issues when we try to compare them. There are varying definitions, inconsistent design, inconsistent primary endpoints, and so if it's difficult to interpret when a device and DAPT strategy are used in a randomization in the absence of a multifactorial design. And just to make that point clearer, the heterogeneity in design is showed in detail, which I won't go into, and as you've seen with the inclusion criteria of bleeding on the various studies on the right-hand panel. So these studies are enrolling very heterogeneous populations with therefore variable bleeding risk. They're going to be variable bleeding event rates. So what's the answer? You know, we need a standard definition of high bleeding risk, and this came from the consensus document from the Academic Research Consortium for HBR, published in Circ in 2019, European Heart Journal the same year. accepted clinical criteria for bleeding, age, comorbidities, renal disease, liver disease, cancer, hematological issues, intracranial pathology, bleeding diathesis, prior bleeding transfusion, oral anticoagulation, anti-inflammatories, and planned non-cardiac surgery in the short term on DAPT is a high bleeding risk, significant. So they defined, as you've heard, high bleeding risk as BARC 3 or 5 bleeding risk more than 4% at 12 months, or an increase or a risk of intracranial hemorrhage more than 1% at 12 months. And to get to that point, they stratified the clinical criteria as major or minor. I'm not going to go through what they are. I highly recommend people look up this data, read the articles. It's very, very useful. More than one major criteria defines high bleeding risk, more than 2 minor criteria. So, for example, 75 and older is a minor. Renal impairment with EGFR less than 60 is a minor, but renal impairment with EGFR less than 30 is a major, and so on and so on. And it can be done easily because it comes on an app, and you can actually do this at the bedside with your patient, do it in the cath lab, making decisions and strategies. Has it been validated? Yes, ARC-HBR criteria have been validated retrospectively based on observational PCI studies, confirmation of 12-month BARC 3 to 5 bleeding rates in excess of 4% in these patients who have the relevant criteria, with stepwise increasing bleeding rates with the increasing number of criteria. So importantly, there is also a 3-fold increase in bleeding events, paralleled by a doubling in the rate of thrombotic events in these patients. So unfortunately, the HBR patients are not only at higher risk of bleeding, they're at higher risk of ischemic/thrombotic events. So it's an important thing to bear in mind. I'm going to finish shortly, but just sort of diverging a little bit by introducing this this consensus, actually a proposed algorithm from European group published in Neurointervention last year, suggesting a way to look at DAPT duration with bifurcation PCI. And bifurcation PCI obviously is associated with a higher event rate, particularly the more complex it is with stent thrombosis. And they break down determinants based on clinical presentation, stable versus ACS, PCI strategy, planned provisional, planned 2-stent, or a bailout second stent, which is actually the highest risk group for adverse events. They further substratify the consideration of DAPT duration based on your bleeding risk profile of your patient, but which I think is incredibly important, particularly in a high bleeding risk cohort facing curtailed DAPT therapy from what we would normally do by using imaging. And I think it's a really important way to look at. Maybe we can talk about this in discussion. So if you've got a stable patient having a single stent strategy with a high bleeding risk with imaging guided PCI, DAPT duration as short as 1 month with a recommendation, and so on. So in conclusion, for this part of the presentation, a published consensus document from the ARC-HBR is aimed at standardizing the principles of design for future studies of devices and drugs in patients with HBR. The document aids recognition for the clinician of HBR patients who, as I said, have both a high risk of bleeding and thrombotic events in clinical practice. And ongoing studies will hopefully provide further device-specific data relating to safety of shorter DAPT regimens when using a standardized criteria, inclusion criteria, design and endpoints. So on that note, I'll stop, and I hope I've fulfilled my remit within 10 minutes, Jack.
Thanks, Nigel. Thanks both for keeping so strongly to time. Now we're going to take a pause to really get some advice from my colleagues across the region on how to really make sense of all these HBR trials. It was 20 minutes of very confusing data for me. So maybe you can start off with some questions first. I would like to ask, actually, then, what is truly the right patient population for HBR trial? And when you saw the trial inclusion criteria in all these trials, are these the patients that you're applying the data in the real world? Maybe we can start with my boss, Aaron Wong, first. Aaron, do you think these results are applicable for real-world practice?
Actually, the right patient population actually is those criteria that actually really that have high bleeding risk. Yeah. So as you can see, for various trials, the definition are all different, and each really may not be applicable to one trial to a certain trial, because the endpoints and also definition is different. So it is good that that the consensus came out with all the right definition, and then on the future trial actually can base on this consensus to recruit patients so that it's applicable to all the patients rather than different trials have different definition criteria. So what is the right criteria? Patient population is those, like you said, in definition, is those more than 4% risk of bleeding in a year. I actually concur quite a lot with the major criteria that is suggested by the consensus. Most of them, it makes sense because those who have bleeding problems, those who have recent surgery, and these are theoretically, I mean, it's very logically that that is have high bleeding risk. But those the minor criteria, actually one of the validation study actually showed that the minor criteria actually doesn't doesn't have it's not been validated to have 4% risk of bleeding in a year actually. So I would sort of concur a lot with the major criteria that is suggested by the consensus. So I think with the consensus, we all have speaking on the same language so that we can apply it on the right population rather than based on different trials have different definitions.
Thanks, Aaron. But I don't still get the answer though. So I'm going to ask William. Actually, William, yes, are these results really applicable in the real world? And which subgroup of patients do you believe the trial results in and you apply your clinical practice?
Clinically, we do see patients with high risk. Sorry, my son is high risk bleeding group of patients. Those with renal failure, where they have this functional platelets from the urea, active cancers, liver. So I think when they look at the comorbidities and they define it as renal, liver, or active cancer, I think that's quite applicable in day-to-day practice. And of course, old age. So patients who are above the age of 75, they tend to have frequent falls and they tend to have more history of bleeding as such. So I think to answer your question, I quite agree with the consensus statement that was published in ESC by Dr. Irvin's group 2019 about who they define the high bleeding risk patients are.
Okay, thanks, William. Maybe I can now get back to Nigel then. You reviewed the trials for us. Your personal belief then, which are the group? Because we still have those on oral anticoagulant, the advanced age, all the ARC bleeding. What are the real world patients that the trials address? Nigel?
Yeah, look, I think it's a sort of it's a continuum, isn't it? I mean, between the major and the minor. And one of the I guess the criticisms of the ARC HBR, it is a consensus document, and as you've heard, some of the minor criteria don't have 12-month bleeding event rates. It's extrapolated, and the minor basically are not weighted, or all the criteria only weighted major versus minor, and it's very binary. But I think, if you're dealing with real-world patients, so a lot of these patients, there's up to 40% of patients based on some data sets fulfill the criteria of ARC HBR coming to cath lab, and they've not got into the regular trials previously. I think the major criteria factors, and I think summated minor criteria factors represent very high bleeding risk patients who we would not have randomized or could not have randomized before, and we've been reluctant to consider short DAPT before because they've got diffuse disease, long disease, small vessel disease. So I think it's very helpful to move forward.
Thanks for that, Nigel. Maybe I'd like to dig a little bit deeper into the criteria and the trial itself. So perhaps I can ask Imran, if the trials don't quite have the event rate of more than 4% or BAC 3 and 5 bleeding, or 1% intracranial bleed at 1 year, can then this be collaborated as a HBR trial, or is just not truly a HBR subset of patients? Imran, your opinion, please.
Thanks, Jack. Well, I think if a trial, mainly the old trials, which we have, where these group was excluded from the data, the validity was scored around less than 3%. So those original trials, which were designed to see the device safety, they were non-HBR trials. And the current definition of HBR more than 4%. If you look at because this HBR ARC was applied on all the studies, all the major studies, and then they get these numbers from those trials, like observation and a binary number. So almost all major trials where they recruited HBR patients, they actually fulfill more than 4% number, except 1 or 2, where minor criteria was used. I think I probably know of Synergy called senior trial where the bleed was around 3.5%. Other than that, I can't think of any HBR study, recent one, where the number is less than 4%. So in my opinion, patients who have a HBR clinical factor or a clinical profile, and at the time of recruitment, if they qualify for the HBR category, irrespective of the actual results of that trial, we should offer them as a HBR group and follow the results.
Thanks.
So by 1 or 2 trials, I will not say that these are not HBR trials. I will still say that as long as the recruitment was based on the actual HBR criteria, could it be ARC HBR, could it be precise DAPT, or any other criteria met, we should probably try to see if we can limit the duration of DAPT in that group.
Thanks, Imran. Maybe I can ask the same question of Prof. Tan, but also to address the audience question from Dr. Kadir from Pakistan. Then how do you take into account all these Asian paradoxes, East Asian paradoxes, and the fact that the HBR ARC criteria was based on a series of registry and trials that was predominantly focused on actually non-Asian patients, and the bleeding risk criteria were not all BARC. There were some other bleeding risk criteria. The outcomes were all over the shop as well. So even though the ARC bleeding criteria was a great effort, it doesn't really based on trials that we can all agree upon in the first place. So maybe Hui-Chin, your opinion on this question.
So I think, Jack, we have to ask ourselves, why was there a need for this ARC criteria of 4%? I think it's really to provide clarity amid all the heterogeneity of trials that we have been faced with. So as was alluded earlier on, this 4% is by consensus. And it's consensus because previous trials that did not include HBR all have a risk of bleeding of less than 3% per year. But when you look at the later bleeding trial like Senior and Zeros and DDoS-free, they all have bleeding risk of 3.5 to about 7%. So the whole reason for this 4% definition actually serves 2 purposes, in my opinion. First of all, it provides the guidelines for us to tailor our treatment to people whom we think are at high risk for bleeding. And secondly, this 4% provides a basis by which you can actually compare your clinical trials and perhaps your quality control initiatives as you move on from here in evaluating all the trials. But at an individual patient's level, when you deal with a patient in front of you, even if he doesn't have all these pre-existing major or minor criteria, the moment he bleeds after your PCI, he is automatically a high bleeding risk patient. And in which case, then you, of course, then you tailor whatever trial data that is available and to try to suit it to your, adjust it and tailor it to your patient's needs. So I think we probably don't have to hang up too much on the exact number of what defines HBR patients, but really what is the patient's profile who is sitting before you, and how can we actually minimize the risk and improve the safety profile outcomes of these patients undergoing PCI.
Yeah, so you would agree that the 4%, if you are sitting in a consensus room like we are doing now, 4% for BARC 3 and 5, 1% for ICH seems very reasonable, wouldn't you say?
Yeah. At least based on the clinical trials.
Yeah, thanks for that, Hui-Chin. Now I'd like to just focus a little bit about what else to look out for. There was a lot of subgroups, a lot of secondary outcome analysis, and maybe we'll focus on that. I'll ask Raj from Brunei, when considering a true HBR trial, what are the other things you will look out for?
Thanks, Rack. Yes, I think when we look at a HBR trial, we have a message. It's a combination of a device and some kind of a drug DAPT strategy that works well for HBR patients. When I look at it, I try to look at the applicability of the trial data to my patients. As Prof. Tang just mentioned, often we are faced with an individual sitting in front of us pre-PCI, hopefully, and not post-PCI. and who's got particularly high bleeding risk, either waiting for surgery, malignancy, something like that. And I want to find the best combination of stent and drug for this patient. And there's a lot of trials at the moment, and we cannot, and as Dr. Jepson mentioned earlier, almost 40% of our patients, and if with Japan data, 50% of our Asian patients fall into the high bleeding risk. So we may not apply the trial data for all our patients, but every now and then we have 1 or 2 patients who are particularly high risk. And I want to create a picture from the study of that patient. So I would look at their clinical characteristics and the angiographic or the PCI characteristics. I need to know if they have included ACS or only stable angina patients, and particularly at the angiogram, whether they've been, there are studies that say we can use 1 month of DAPT, but we cannot use overlapping stents. So I need to know that if this patient has a long lesion and needs more than 2 or 3 stents, I cannot actually use that data and use that particular stent and drug strategy. So I would, and bifurcations, 1 stent or 2 stents, that makes a difference. So at the end of it, when I look at a study, I try to have a picture that I can refer to. So the week after, if I have a patient, whether that particular clinical and angiographic picture is similar to the patient that's been studied in the trial, and whether I can apply the trial data to my patient. So that tends to be my focus when I look at the HBR studies.
Thanks, Raj. A very practical approach. Maybe I'd like to ask John then a bit more technical trial question. We saw a lot of subgroup analysis and subgroup outcome with p-values here. How do you look at all this subgroup unpowered analysis in the HBR trials? Is it validated to make those conclusions, John?
I think when we look at subgroup analysis, we always have to look at it with some caution. I think they definitely provide some data when we are looking at the different subgroups. But as I said, we need to see 2 things. One is whether this subgroup analysis were planned, in the initial planning of the study. Second, whether these are powered to detect these differences, or whether these are kind of like subgroups that came up along the way and people were kind of looking for differences. So I think when we look at these subgroup analysis, even if they are significant or not significant, we have to really take some of these with, as I said, a little bit a pinch of salt. I also want to add early on to what Raj said, when we're looking at some of these HBR trials, I think we look at 2 things. One, whether the patient fulfills the definition of the HBR criteria. And also the other part that really is quite important, especially for interventionists like us, is what are the lesion characteristics that are being treated. Was this a left main kind of stent? Was this complex bifurcation stenting? And some of these are covered in various of the trials. And this gives us a little bit more confidence, when we want to give a shorter DAPT, especially in some of these more complex PCIs.
Thanks, John. Again, difficult to address in a very heterogeneous population, but that's also very key. Then maybe I can just switch track to what was asked by John. Tang, then is it really important to include also ACS patients in the HBR trial? Because ACS patients are really the very high ischemic risk patient, right? So if you are throwing this lot into a HBR trial, is it validated to do that? Is this what is needed in the real world? Your thoughts?
Yeah, I missed that. You addressed this to me, right?
Yes, Tang.
Yeah. Sorry. Yeah. So, I think you're right. This is the very dynamic. I'm always a little bit concerned about the ACS cohort that is also deemed high bleeding risk. I think in terms of scientific validity, I mean, if you define it a priori, as John has mentioned, then it's certainly reasonable to carry on and perform the analyses. But actually, I always ask myself, I mean, and maybe we can pull the panel here as well. I mean, how often do we really stick to this 1 month DAPT for the patients that we consider high bleeding risk? Because I think on a practical, very very few of us really at that day 30 or day 31 actually very strictly tell them to stop that second end plate. So I think as a concept, HBR is great, but in the execution, I think in the real world, that the execution is not really the same as in the trials. Thanks.
Very, very good comment from Chee Tang. Maybe I'll ask Chee Tang's question to Dinesh then. You have a HBR patient and you have an ACS patient now. Is it important to include an ACS patient in the trials, and are you stopping them at 30 days or 28 days for that therapy, Dinesh?
Yeah, so I think I kind of agree with Chee Tang to some degree. The idea here is you need to have the reassurance to be able to stop it if you need to stop it, right? And that's the only thing. I can't see myself stopping DAPT very early in most patients. And that little slide that Nigel put up earlier about the high bleeding risk and the bifurcation and little guidelines on 1 month, 3 months, 6 months, that is a good way of looking at it. But I think more than anything else, I would like to continue using the DAPT for as long as I can in the patient. And once again, the patient may present otherwise. When you've got an acute coronary syndrome patient in front of you, you're doing a bifurcation lesion, you think everything is okay, you've not had a chance to assess the patient up front. You put in a whole load of metal, and you'd like to be able, let's say you've done a DK crush technique, and you'd like to be able to continue a DAPT for a longer period of time. But circumstances change, and then you need to be reassured that you can stop it early if the patient develops a bleed. So that's how I'd approach it. I think most of us would as well.
Thanks, Dinesh. Maybe after all this discussion, I'd like to ask TK, who's a very astute clinician, how do you then extrapolate from all this trial result to a real-world complex patient again? Maybe to give us some clinical tips and tricks, TK.
Yeah, can I just talk? I'll just refer a little bit to the earlier discussion, and I could be wrong, but my impression is that we are a bit confused with this HBR thing, because my impression is that the original HBR trial was done not to show that it's safe in HBR patient. It's because at that time we have to use long duration of DAPT for DES, and the HBR trial was designed so that it was ethical to stop DAPT at 1 month. It was done purely for ethical, to get the study protocol approved by the ethics committee that in these patients with high bleeding risk, we can stop the DAPT at 1 month. So the most important data we want is the safety. And the studies that we've done, can we refer to the real world, more complex patients? Well, what we want is safety. And we've seen from all the short DAPT trials that the safety is not an issue. There's not an increase in ischemia, but there's definite benefit in terms of reduction in bleeding. So that was the benefit of a short DAPT. So then that brings to the later part of our discussions where I said that we would not routinely give a patient 1 month DAPT, but if there's a need, then we know that we can do it safely. And similarly, let's say if a more complex patient, or patient with more high bleeding risk characteristics, we know that stopping DAPT would be safe because that has been demonstrated by all these trials. And the benefit of reduced bleeding, we would expect even more benefit in those group of patients. So I would think that these results is extrapolatable to the more complex patients that we are treating.
Thanks, TK, for refreshing us back to the original intent for that. Maybe Patrick can jump in also. Do you agree with TK?
Yeah, no, I agree with TK in the historical, why the trials were done. But I also want to build on the question that was asked. It's actually building on all since Nigel's comments, John's comments. I think we're trying to refine the tool to assess our patient's risk for ischemic thrombotic risk versus bleeding risk. So we used to talk about DAPT duration. So based on their presentation, then we talk about type of DAPT, which is different now. Then you got the device-oriented trials. You got your anatomy of, like what John said, where is the anatomy, where's the stents placed. Then you got imaging, which is going to confuse things further. And then, so I think, and so the last slide where Nigel shared about, where we can try to add in 3 components: your bifurcation complexity, your imaging, and then your presentation. I think we still got a few more to add on. So I'm not sure whether we'll ever get the answer from the clinical trials, but it is a guide to where we are going at the moment. That's my thoughts.
Thanks, Patrick. When those comments are made, I saw Chee Tang and Paul Ong shaking their head. So I'm going to ask Chee Tang to comment first, whether they agree or not. Chee Tang.
Yeah. Thanks. I think Paul has the same sentiments as me. I hope we got this mental connection thing going on. But no. I mean, I think TK's points are great, but I don't fully agree that these 1 month trials are any. They're not meant to. They're not trials of length of DAPT duration. They're stent trials, right? So, and if you look at the event rates actually in leaders free and to a certain extent Onyx one, at 12 months, the event rates are typically higher than a typical stent trial in the modern day. And that you could argue is because HBR patients have high ischemic risk characteristics as well. But we really don't know if what would have happened if we kept these patients on 12 months DAPT, because that's not in the trial design. So I think we need to be a little bit cautious when we go around spreading the message that 1 month DAPT is completely safe in these patients just because they met the HBR criteria and they had the stent that was studied in this kind of trial. Thanks.
Okay, Paul, you want to jump in here?
Yeah, I kind of echo what Tang said. And I normally fully agree with everything TK said, but except that if we look back at history a little bit, DES is supposed to be the EVO that require a lot of prolonged DAPT. So at the time when we have high bleeding risk patients, the default was still pretty much putting in bare metal stent. And I think this is where the leaders free trial came in. You actually compare a newer drug-coated stents with a bare metal stent in this group of patients and using a very short DAPT and demonstrate the safety and efficacy. I think it's not purely just to stop DAPT, but actually to prove that the DES is as safe as a bare metal stent. That's my point number one. But secondly, because of this trial, that's obviously get a lot of airtime for the company who invested in the trial. It sparked a whole host of Me Too trials. For almost every single stent company came up with a HBR trials, and therefore, as Nigel very eloquently summarized, different endpoints, different definition, and that we got very confused. But I think if we go back to the chase, is if what Raj was saying, if you're seeing a patient in HBR, currently, if you look at a lot of these trials, it actually doesn't tell you whether it's safe to use 1 month DAPT on that patient or not. All it tells you is this stent is as good as the other stent if you do 1 month DAPT, or this stent is as good as historically, 10 years ago when we were using 6 months. Actually, apart from, as far as I'm aware, MASTER DAPT, that's probably the only trial so far to say that if you have a high bleeding risk patient and you implant this particular stent, it is actually okay to use 1 month DAPT because it's better than you going down 12 months. So that's just my thoughts.
Thanks for clarifying about that trial. Hui-Chim, your final comment on this topic before we move on? You're muted, Hui-Chim, sorry.
So my comment is that the current HBR trials did not really show that it is better than the shortened DAPT is not definitely better than somebody who take a longer time, but but it is safe to do so in patients who need to be on it. The only trial, like I said in my comment, is a MASTER DAPT, and that really shows that in patients whom you need to give shorter duration, it is actually there's no price to pay as far as ischemic endpoints is concerned compared to people who are on the standard long DAPT regimen. And that also applies to the bi-risk group of patients. That means both ACS patients as well as high bleeding risk group of patients will benefit from this shortened DAPT. So if you need be, you now have a data to support yourself.
Thanks, Hui-Chim. So maybe I'd like to then go back to Paul to answer this question that you really alluded to it. So we have biosensors with the first trial in leaders free, then we have Synergy, Onyx, Auxero, Zymes, So is this going to be a class effect? Does the stent really matter, or can you not extrapolate, Paul?
I think you have to be careful when it comes to extrapolating it. But I think honestly, in the real world, some lab doesn't carry certain stents. But all labs looks after high bleeding risk patients. So like it or not, in the practical ways, you have to say that most of the contemporary stents seems to be safe to keep the DAPT duration short. So I think that's probably the most straightforward answer I have for you. But if you're purely looking at data, then I think Chee and also early on Tang already said actually only one of two companies actually have done the trial to show you.
Thanks, Paul. Yu Xiong, in your cath lab, if you're going to pull out a stent for a HBR patient, do you think it's a class effect or you reference to trial data? Yu Xiong?
Jack, I think this question is kind of hard to answer. It can be easy to answer in one way, but it's also hard to understand in the other way. You all will wish that it's a class effect, so that we don't have to worry about what stent we use. And some of the stents already show that you can do it, but I'm not sure whether we can extrapolate to every single stent there is out there. So I would still think that if I need to pull out a stent for HBR patient, I'd rather pull one that I know that has some data to back me up, rather than just randomly choose one and hope that it's a class effect and everybody else is safe. So I think, yeah, data is still important, and I would like to pose another question. Since there are some stents that have such short DAPT data, why don't you just use that particular stent all the way for every single one, whether they HBR or not, so that in case that we need to turn HBR later on, to stop the stent. What do you think, Jack?
Thanks, Yu Xiong, for that. Maybe then the next question that extrapolate from Yu Xiong and Paul's answer, maybe to Fahim. Then why don't you just treat every patient as a HBR patient? I think TK also say that you can't predict when they're going to bleed, develop malignancy. Why don't you just, I advise everyone just use the HBR stents for every patient, Fahim?
Yeah, thanks, Jack. I mean, that's a good question and it's an important point. My problem with these HBR criteria are, and I understand the need for those criteria because you had to, as Wei-Chim said, you had to standardize the whole issue. But the fact of the matter is that even if you take out the people who had a GI bleed yesterday and if they've got cancer and they've got cirrhosis, those big major criteria. I mean, when you look at our practice, you really have to ask the question, who the hell is not HBR? And patients are either HBR or they will become HBR sooner or later. Take somebody 75 and above, that's very common. And then a little bit of anemia or a lot of anemia, they become HBR. A little bit of renal failure or a lot of it, they become HBR. So I think it is probably reasonable to look at every patient with an HBR lens and sort of consider them to be HBR in the making if they aren't already so. And so that goes to what you were just alluding to, which is you really have to do the best possible job, whether it's imaging or whatever modality you use, but get the best possible job because anticipate that at some point or the other, you may have to truncate DAPT. Sort of in parallel to this, the other problem with the HBR criteria is the fact that while they predict a risk, the fact of the matter, and that's where the conundrum is, that most patients don't bleed. So you will have this 80-year-old with a bit of anemia, and they will go on 2 years of DAPT, and you'll never know. And they'll do absolutely fine. And so that's where the art comes in, that you've done a super complex procedure with multi-vessel stenting or bifurcation stenting. Should you stop it at 1 month or not? I think that nobody knows the right answer to that, and it becomes a sort of literally a judgment where you have to sort of look at the patient as a whole and not as if you're just a technician who did put in a stent, and that's where the decision making comes in. That do you consider this patient HBR or not? But in general, I will agree that most patients have to be looked at with the HBR lens and then treated accordingly. And then one final point, which is sort of the elephant in the room, is that while we talk about truncation of DAPT, we're always talking about dropping the P2Y12. And there is emerging data that suggests that perhaps if you continue the long-term P2Y12, a lot of them will continue to do very well and not bleed. And so that's something that I will throw at the panel. But in the short answer, I think that yes, we do need to consider most of our patients as HBR in the making if they aren't already meeting those criteria.
So we are not even going to the pharmaco part of it. It's already quite confusing. So maybe I'd like to ask Chris Khoo the same question though, like what Fahim made. Are you in your real world practice, really treating each patient like HBR patient? Is this practical?
I think it's a practical concern because I think, like many people in the panel have actually alluded to, a lot of patients actually end up being a high bleeding risk patient. I'm sure many of us in our practice have actually seen patients subsequently require surgeries, subsequently develop bleeding from the GI tract, and they've all had to stop the GI, the DAPT, or at least one antiplatelet. But where I'm coming from, besides being an interventionist, is because I have a side interest in cardio-oncology. And what you actually notice is that there have been observational studies that show that, number one, cancer patients are more at risk of AMI. And I think the second thing is that all patients who develop an AMI, I think there have been signals to show that within 90 days, a lot of them are actually at increased risk of actually developing cancer. So these are cancer-naive patients who develop an AMI. And within 90 days, they tend to actually show an increased signal of cancer developing. And whether that's because of actually DAPT unmasking a GI tract tumor, or whether it's that because of increased hospital visits and consultations picking up cancers. But we do realize that actually a lot of these patients do actually unmask a cancer. And that brings up the whole question about stopping your DAPT earlier for biopsies, stopping your DAPT because of chemotherapy and whatnot. So I think the point is that a lot of these non-HBR patients actually do become HBR patients subsequently. I think it is a sensible strategy to consider all patients to be HBR, because there really isn't any downside to doing so, at least at this point, I feel. Thank you.
Thanks, Chris, for those comments. Maybe then, if everyone is HBR, would then your go-to two-stent be a two-stent strategy or provisional approach for bifurcation lesion? Then maybe Aaron can take this. For true HBR, for all patients, should it be provisional?
Actually, I was just going to mention, I just did a hot CTO, was very successful, and then MO called me out a few hours later, patient had PR bleed. So this is exactly the case that we're discussing. So which could have treat the patient as a HBR patient. So to answer your question for bifurcation lesion, I think for me the principle is the most important is success of the procedures. You can't try to do a provisional one when the side branch got compromised. So success of the procedure is the most important one, and I would try to put in less metal as possible, meaning trying to avoid two-stent strategy, because the risk of stent thrombosis with shortened DAPT might increase. And also, especially if it's left main bifurcation stenting, then imaging is vital. I think, to make sure that all the stents stent sites are fully expanded and the risk of event is cut to minimum. Yeah.
Thanks, Aaron. Hui-Jin, will you agree with that for a bifurcation lesion?
So Jack, if you look at the Onyx 1 clear study, there was a bifurcation subgroup that was talked about just now. The bifurcation subgroup constituted 13% of the population that was studied, and it was compared with the non-bifurcation group, and there was no difference in terms of ischemic outcomes with the 1 month DAPT, suggesting that a complex PCI with bifurcation lesions perhaps can give you as good a results with a shortened DAPT. But I actually have to draw cautions to a number of pointers here, because that populations of bifurcation in the Onyx 1 study was 86% provisional stent strategies, suggesting to me this is not a complex bifurcation lesions that we are dealing with. And I think the approach to using provisional versus two-stent in the bifurcation stenosis never had HBR as a consideration. Based on our Asia-Pacific consensus, the choice of a stenting strategy depends on the clinical presentation as well as the lesion morphology. HBR just come in here and perhaps add to a little bit of the complex directions, but the primary driver for the choice of stenting strategy has to be the lesion morphology and the clinical presentation.
Thanks, Hui-Jin, again, very astute comments. Maybe at this, we're going to close it in the interest of time. And I'd like to ask KK followed by Nigel to give us some of their thoughts after you guys gave the talk and you heard all our panelists, maybe your summary thoughts for the HBR section of this. KK, please.
Thanks, Jack, and it was really good to hear the different comments. I think for the Onyx 1 study and a whole series of sub-studies, the key take-home message is that insofar as the need for 1 month DAPT in these high bleeding risk patients, it is a safe and efficacious stent. And overall, I mean, you know, the message that I've gotten in listening to these to the discussion is that especially since we can't always predict bleeding that happens after the stenting procedure, you know, the burden, or rather the body of evidence reinforces the safety of this stent platform. So I think that's an important take-home message. Having said that, I mean, you know, there are other stents that are out there in the market that have tried to meet that that basic premise, and we should be mindful of the data coming out for all these different stent platforms. Thank you.
Before Nigel comments, can I ask Nigel to address a question that some of our panels asked? You skip over the DEB as one strategy. Would DEB truly, in your trial review, be an option for HBR patient, or there's no difference?
Look, I think at this moment in time, in my opinion, it's probably niche. I think it was one small trial. I think there is some use outside ISR, use of DB in small vessel de novo disease. In our practice in Australia, it really is a niche device. So in our environment, it's not going to challenge a stent in HBR at the moment. And additionally, I think we need a lot more trial data to substantiate that.
Do you have any closing comments for the HBR discussion so far?
No, thanks, Jack. I've really enjoyed it. I think the discussion's been very good. But I think, you know, clearly HBR patients are an represent an unmet need in the lab. We've evolving data, but still limited data. I think a study, as Jim said, the MASTER DAPT study is incredibly important. A very big study of platelet duration, short of standard versus short. And I think we will look at what happens, the implications of high bleeding rates impacting on all-cause mortality beyond 12 months. So I think it is a bit of a paradigm shift. If we think a few years ago, we were using a lot of 2B3A, certainly in Australia, upstream in ACS, RheaPro in the cath lab, we realized that was a bleeding catastrophe, and bleeding carries in ACS a cardiac mortality at 12 months. And if I'm wearing my clinical trials hat, tracking bleeding as an adverse event is difficult, and it takes our trialists a lot of work to work out what the hemoglobins were in hospital, what's happened in 30 days, and so forth. So if we don't capture the data, we don't know what happened, and we don't know therefore what the knock-on effect is. Obviously, we're looking at all-cause mortality. So I think the high bleeding risk patient is a high ischemic patient. I think that's an important concept, and I think we need consistency. I think that's what we'll agree on with definitions in moving forwards, both clinically in the lab and with trials. So yeah, thank you.
Thanks, Nigel. Again, very good comments. TK, just now I didn't give you a chance to rebut all the comments. So maybe your rebuttal before we go to RDN. TK, you like to unmute yourself first?
Sorry, I was misunderstood. I was not suggesting that we should use routinely 1 month DAPT. Yeah, what I was saying was that, you know, all these trials are done to demonstrate that these stents, for all these new stents, the DAPT can be shortened to 1 month if the need arises. Yeah, you know, and that's the main purpose of all these studies, really, and not really to encourage everyone to use only 1 month of DAPT.
Thanks, TK. Glad you had a chance to clarify that. So now we're going to move on. Thanks. I really enjoyed the discussion at HBR. We'll never finish. Fahim actually want to move on to P2Y12 versus aspirin and maybe 12-light results, but really no time. So we're now going to transit a little bit and change track and mottos to Tang. Just bring us through renal denervation first. Tang, thanks.
Okay, thanks, Jack. You can see my slides?
Yeah, go ahead.
Yeah. Okay, right. So thanks to APSC and trying for the opportunity to, in I think 10 minutes, tell you everything that you need to know about renal denervation. So complete change of tack now from the very dangerous high-risk patient that is the HBR patient to what many people consider as very low risk, hypertensive type people. But I would like to try and convince you that actually this is a very important issue, and that's something that we really should be paying attention to. So these are some of my brief disclosures. So I think we don't really need to harp on this too much, but hypertension, high blood pressure is still a very major problem in the world. So depending on which geography you're in, the prevalence of hypertension can range from about a quarter to as much as in excess of a third. And this is same whether you're male or female. So really, it's a problem that's not really going away despite all the so-called advances that we've had in pharmacotherapeutics over the last few years. And we know this is very important because actually every millimeter of mercury of blood pressure reduction that you have actually translates into significant reductions in terms of your outcomes. So just now we were going on and on about 4% and etc. But if you bring down your blood pressure by about 5 or 10 millimeters mercury, your relative risk reduction in terms of experiencing any of these major adverse cardiac events is substantial. So something really for us to perhaps always keep in mind and try and impress upon our fellow colleagues as well as our patients. So that having been said, the problem, of course, is that we know a lot of people have hypertension, but very few of them actually get diagnosed. And of those who get diagnosed, very few actually get treated. And of those who get treated, very few actually end up being well controlled. So this is data from NCD. So what it shows actually is that only about a fifth to about a quarter of patients actually so-called controlled hypertensive. So there's a whole big proportion of people who unfortunately are running around with uncontrolled, poorly controlled hypertension. So until now, really, the extent of the data, the kind of options that we have were really medication. And high blood pressure, hypertension has really lagged behind all the other modifiable risk factors. We've got now fancy diabetic drugs, fancy lipid-lowering drugs, but hypertensive drugs, not so much. So I put it to you actually that we need something else, obviously, and the people who have been keeping an eye on the field know that really renal denervation is probably the most promising adjunct to the management of high blood pressure. The problem, of course, is that the data has been mixed. So nowadays, when you talk about renal denervation, people you frequently say things like, "Are you sure it even works?" So let me just quickly go through the details of the spiral hypertension OFF-MED pivotal study, because this is really a demonstration of the science. So in this study, you had patients who had high blood pressure and they were not taking medicines. And this was proven because before enrollment, before randomization, they went for drug testing. Okay, so they were drug tested, they had urine and blood tested, and they were definitely drug-free. And then they were randomized to either renal denervation or a sham procedure. And as you know, renal denervation trials now have this exceedingly high bar to go over, which is the sham control. So patients on sham, they go to the lab, they have a puncture, they have everything done to them really except for the actual procedure. So there really is a very high detail of control here when we're talking about renal denervation. And of course, they were followed up and the endpoints were measured at 3 months. So these are the starting blood pressures at enrollment. So you can see the actual proper high blood pressure. So on office, about 160 systolic, and on ABPM, the systolic about 150. And these are the results. So sham control, no difference in the blood pressure measured at 3 months. But in those who underwent the procedure, the renal denervation, at 3 months, you could see an appreciable, statistically significant difference in terms of both the office as well as the 24-hour ambulatory systolic blood pressure. And this is the slide that really always impresses me the most. So this is looking at the ABPM results. Okay, so this is at baseline, RDN on the left, sham on the right. And then after they have the procedure or the sham measured again at 3 months, you can see there are reductions in blood pressure for the RDN group. And these reductions are throughout that 24-hour period. Okay, and this is especially important because, our patients who are so-called taking medicines, sometimes they forget, sometimes they take medicines at funny times. So the degree of blood pressure lowering that you get from medications is inconsistent. And we know this because, we keep drug diaries, we look at people when we measure their ABPM, etc. But with RDN, based on this data, you can see that there is an always on kind of effect in terms of blood pressure lowering. So that's all very good. That's up to 3 months. Some people say that they have a longer term. So now these are data that has been really presented over the last year or so. So this is a histological study. You can see that at 7 days post-ablation, there's a very marked reduction in nerve activity already. And this is 6 months. 6 months post-ablation, you can see that there is no regeneration of the nerves. Okay, so in terms of long-term safety and efficacy, we also are very fortunate because Medtronic had the foresight of creating the Global Simplicity Registry, which has been tracking patients who have undergone the renal denervation procedure over the last few years. So the whole GSR had about, I think, 3,000 over patients. But in terms of the newest technology, the Simplicity Spiral Catheter, we now have data that has been presented for up to 3 years. And this is very important because this is the device that we are using now. And so this is the kind of headline results. This is looking at safety. So a lot of people are concerned because you're going to the kidneys and doing things to the kidneys. But suffice to say, at 3 years, there is actually no signal of any harm to the kidneys. There's no new renal artery stenosis. There's no major sustained creatinine elevation. And the rate of end-stage renal disease at 3 years is thought to be consistent for these group of patients because at the end of the day, they are all hypertensive patients. So no real safety concerns there. And in terms of efficacy, if you look at this, this is reductions in blood pressure of this as well as 24-hour ABPM. You can see that blood pressure comes down very quickly. By 6 months, you can measure a difference. And this is sustained up to 3 years. And if anything, it seems to be getting more as time goes by. And if you look at the data in a slightly different way, this is baseline, 6 months and 3 years. If you look at this group of patients here, these are the so-called controlled patients, less than 140 millimeters of mercury. And you can see at 3 years, nearly about 36% have now reached the so-called controlled stage. And this is without increasing medicines. Okay, so this is the mean number of medicines that they're taking. If anything, the mean number of medicines has started to decrease. So you achieve this blood pressure control without having to increase medicines, and in most patients, you can actually start to reduce some medicines as well. And then the next barrier that physicians like to push back on is they like to say, hey, I know this thing, maybe it works, but my patients, they don't want to have something invasive. So based on this, we know that the current guidelines from both the Europeans as well as the Americans have really put a very strong emphasis on shared decision making. And speaking to this has been this study that was presented last year. This is the patient preference for intervention study, and this was designed in collaboration with the FDA. Basically, it sampled 400 patients who are hypertensive based in the US, and they were asked really about their preferences in terms of their care. So very much like one of those threshold to treat type surveys. So what the survey found was that patients were actually willing to accept just a 2.5 millimeters mercury reduction in office blood pressure and the risk that they would accept to get this kind of benefit was about 20%. So actually this treatment-related risk that they're prepared to accept is greater than the observed risk in any of the trials. And hence, if you extrapolate this even further, if you're thinking, if you offer them 10 millimeters mercury reduction in their blood pressure, up to 3/4 of patients would be willing to undergo an invasive procedure. So in summary, I would like to put it to you that the renal denervation procedure with the current Simplicity spiral catheter is effective for sustained blood pressure reductions, and more importantly, equally importantly, patients are open to intervention. There are durable reductions. You can see that by preclinical findings. The GSR has shown long-term, unparalleled real-world data up to 3 years, and now we have data about how willing patients are to undergo these kind of procedures as in exchange for better outcomes. Thanks very much.
Thanks, Chee Tang, for keeping to the time. Raj, do you have a question?
Thanks, Jack. Chee Tang, thanks again for the presentation. So just a practical question. As you know, we are on the verge of starting an audience service in Brunei, hopefully. And as you know, we have been on the verge of starting a service for a couple of years now. And you very kindly shared some insights from your service. A couple of years ago, I think we chatted about it. And because of COVID, it's not quite happened. So I was wondering, do you have any tips and tricks from your experience when we are starting a new audience service, especially in terms of patient selection, the kind of workup we could do for patients who qualify for RDN?
Okay, thanks, Raj. That's a huge question, actually. So I'll try and break it down bit by bit. I think the patient selection is probably the most key thing at the moment, trying to identify the patients that were likely to have the most benefit. I think the new data that's coming through is very helpful because it really is starting to expand the kind of patient population that we want to target. So previously we were concentrating mainly on the resistant hypertension cohort, but I think now as we get more and more data, this is probably going to become applicable to other patients as well. I think the biggest barrier to starting a service, unfortunately, is still at the moment issues with in terms of patient and physician knowledge, hence leading to referral pathways, etc. And I think reimbursement also comes into it because at the present time, as you know, most of the guidelines have not really caught up with the clinical data. And because of that, reimbursement is an issue. I think we have to be very upfront about this. And so until we can get everything all lined up, get all our ducks lined up properly, it is going to be quite challenging. So at the moment, I think it's still work in progress, even here in Singapore. And I'll be actually very interested to hear TK's views on this because actually TK has been doing a lot of the procedure actually in Sarawak. And so maybe TK, you could chime in.
Yeah, thanks, Chee Tang. I think your point about the patient selection is correct, And then when you're starting off a program, you don't want it to die. You don't want the program to die prematurely. So you want to get a good result. So, and for renal denervation, because we have not yet been able to properly define the perfect patient for renal denervation, so there is a definite non-responder rate. And that rate varies from institution to institution, depending on who you speak to. But I think it ranges in the region of about 20% or so. So there's no non-responder rate. So how do we do? So I think for ourselves, when we started our program, we concentrated on those hypertensive patients who has failed everything. So these are the patients who are on 4, 5, 6 medications, and the blood pressure is still hovering around 150, 160. And in particular, some of these patients has had end organ damage or a complication of hypertension. They get admitted with heart failure because of hypertensive emergencies. So these are the patients where we tell the patient, we've tried everything already. There's nothing for you to lose. We will try this, right? And if it works, the patient will get a lot of benefit. If it doesn't work, well, we're back to square one. We try to look for another solution for the patient. And the thing about renal denervation is the higher your starting point, the higher your baseline blood pressure, actually the absolute reduction is better. So you tend to get a better outcome. And that would give you the confidence to keep the program going. Yeah.
Thanks, TK. Hui Jim, your question or comment?
So I think, Jack, you know that the renal denervation has really gone on a story path. From that, of a widespread enthusiasm to a sudden disillusionment because of the simplicity, HTN3, lack of efficacy. But I think now we are quite clear that it is an efficacious mode of therapy. It can lower BP of between 4 to 6 based on what you look at, whether it's office or it's a 24-hour BP. But I think we need to look at the value of this therapy. The value of this therapy is that this renal denervation therapy effect is actually equivalent to one antihypertensive therapy. So if you have a patient whom you're considering adding on one more antihypertensive therapy, that is equivalent to our RDN therapy. But RDN, as Chee Tang mentioned, has got an advantage is that it is always on. So the effect is always there. Unlike when you take a new medicine, there's always this pharmacokinetic profile, there's this dosing regimen, adherence, and so forth coming in. So this RDN gives you that assurance that the BP effect is always on. But RDN, as also mentioned, has got multiple limitations. The biggest limitation here is that we cannot predict the individual response to it. So we have earlier on used RDN in our patient, my patient didn't respond. So individual response cannot be predicted. It is interactions with some of the medicine that have never been studied in certain of the trials, such as spironolactone alpha blocker. We don't know what is the interaction here. And of course, the sustainability and durability of this therapy is something that we are always very concerned. So it is a decision-making process that we will have to make with the patient. As far as if you want to start on an additional antihypertensive therapy and he's not keen, RDN is an alternative to an escalation of BP, but it's never meant to reduce antihypertensive therapy, nor to replace it at all.
Thanks, Hui Jim. Again, great remarks. Maybe addressing some of Hui Chin's comment, I can get Paul to ask Paul when perform RDN, is there any safety concerns that we may have, Paul?
Right. No, safety concern, not really a big issues. I guess the really tricky ones would be those patients, and none of us really know, are the patients who are on dialysis, where the renal arteries are probably a little bit atrophic. I think that's group of patients a little bit careful. But otherwise, for interventionists, it really just femoral access, mostly sort of access related trouble. But I think coming back to the starting of the program, I think Chee Tang very adequately put in the discussion about patient's preference, but it's also the issue of insurance preference is also important. I think getting the right patient, convincing to go through an invasive procedure, and yet not able to promise that you are the one that will respond, it's quite a few hurdles to jump through. And then at the end, like in Singapore, if you have to also ask them to cough up roughly about 30 grand to do the procedures, then that becomes a deal breaker.
Thanks, Paul. And also the second concern raised by Hui Chin was the ask about durability. TK, do you have any data supporting and your experience for durability?
If you talk about published data, I think Chee Tang already showed us the data from the Global Simplicity Registry, which shows that the blood pressure reduction was not only sustained, but it continued to drop over a period of 3 years. And over that period, the number of medications did not increase; they actually decreased slightly. So I think we have to attribute that decline in blood pressure to the procedure itself that the patient had 3 years ago. Now that is published data, and people always say, do you have longer data or not? Which is why now the Metron is going to extend the GSR study into the GSR defined, and will follow the patients up to 5 years because people want longer data. All right, I've come across a publication, a study coming from Lithuania, where they've looked at the outcome in their patients, several hundred patients, 100+ patients, 4-year outcome, and the blood pressure reduction was sustained up to 4 years, which I'm not surprised. Because for those centers who have been doing renal denervation for longer than 3 years, from our own patient cohort, we know that the blood pressure reduction is sustained. I know from my patients, I have patients who had the procedure done 5 or 6 years ago, and the blood pressure is still low, But people need proof. People need the proof, right? So hopefully the GSR defined 2 years from now, we'll have the 5-year outcome, and then we'll be able to prove that it will be sustained up to 5 years. But of course, at that time, people will say, can it be sustained longer than 5 years? You see, we are never satisfied, right? Yeah.
It's not a cure. I read. KK, you have a question about RDN?
Yeah, thanks. I think this is a very nice overview and really like the discussion. Can I ask, what about cost effectiveness? Because, to Hui Chin's comment that effectively it is a one drug equivalent. So taking compared to an ARB or calcium channel blocker, which has X dollars, do we have cost effectiveness studies to inform us on how do we translate that in terms of $30,000 expenditure upfront versus a sort of a slow mortgage payment over a few years?
Bank rates are quite low now, but Chee Tang,
Okay, I'm sorry about this. I'm not entirely sure where the 30,000 mark came from. So maybe that's okay. But I'm not entirely sure where that benchmark came from. I think in terms of the cost effectiveness studies, the issue really is that we are accruing data. So sorry, this sounds like a really wishy-washy answer. We have data from the beginning years where we looked at the big reductions in terms of blood pressure reduction for the severe resistant hypertension cohort. So like TK mentioned, if you have very high blood pressure, actually you have significant, it's likely that you will have significant blood pressure reductions. Not everyone, maybe about 80% of the cohort will have at least 10 millimeters mercury, but the average reduction in HTN1 and HTN2 was about 30+ millimeters mercury systolic. So if based on that, they did the cost effectiveness studies, and of course, they were very, very favorable. But then, since after that, as Hui Chin has already alluded to, not so favorable in terms of the HTN3 studies. yes, you'll get blood pressure reductions in if you go for the RDN procedure, but you also get blood pressure reductions in terms of the sham. So, very confusing. And that's why now we have to design better trials to try and tease out the real relationship, how much blood pressure reduction we actually get. I think the 3 to 4 millimeters mercury reduction that Huixin alluded to, that really comes from the OFMED study. So we don't know for sure how much reduction we will see if patients start off with a higher blood pressure, if they're on other medicines, for instance. We're still awaiting the full results of the HCN ONMED study. So that has been promised, akan datang, for quite a few months, years now. So hopefully we'll get that soon. Yeah.
I just want to quickly jump in here before. I do not know how much it costs. So to be fair to those who take our numbers as gospel truth, just to say that, I would leave it to the individual hospitals to say how much the treatment costs. So yeah, I was just catching on to a number that stuck in my mind. So thanks for that, Chee.
Okay, can I make some comments about the cost effectiveness thing? Because this issue always comes up. All this renal denervation things I do always comes up. And the thing is, I don't think when you do a cost effectiveness analysis, you cannot compare the cost of the procedure against the cost of medication. Because the effectiveness of medication depends on the patient taking the medication. So let's say in the GSR, we said the one procedure of renal denervation, okay, minimum can lower your blood pressure for 3 years. But for the patient to have controlled blood pressure for 3 years, he will need to take that medication consistently for 3 years. And how can we be sure of that? So if the patient did not take, right, and the blood pressure is uncontrolled, then the patient suffers a stroke or heart failure, they need to factor in the cost of treating a stroke or heart failure. So it's very difficult, to
very difficult
compare.
But nonetheless, it has to be done, because the opposite is true, right? Just like we cannot guarantee that the patient will take the medication, we also cannot guarantee there will be no complication during the procedure, right? So I think we just have to play the numbers out, and that will be factored in, right? Because when we average the numbers out or look at all the overall outcomes and then the cost, and that's why you have all these complex, better educated people than me doing the cost effectiveness study. I can never really understand it. I just say, okay, fine, it's cost effective, here we go. But I think the point is well taken. Patients do play a role, not just in decision making, but also in medication compliance. So I think that's well noted. Thanks. Sorry for interrupting.
Thanks, everyone. So it will come to the hour. Before I ask Huixin to provide his final wrap-up closing remarks, I'd like to thank all the 3 speakers, Nigel, KK, Chee, Tang, for wonderfully sticking to time, and everyone for providing their astute remarks and comments to this advisory board. And for all the people who stay until, I'm surprised, 350 people will stay all the way with us until the last minute. Huixin, your final closing remarks, then we have to wrap up. Thanks.
Well, thanks, Jack. Well, my impression of renal denervation therapy is that it is the first device-based therapy now that we can offer to patients with hypertension, and that is now has got a proven efficacy based on all these latest trials to tell us that it can lower BP to an extent that we can expect a significant reduction in terms of cardiovascular event and mortality by the magnitude of its reduction. It serves as an alternative to added antihypertensive therapy, in my opinion, because of its always-on advantage, minusing all the adherence as well as dosing problem. But it has questions that still need to be answered with regard to its durability, its interactions with all the existing antihypertensive drugs. And finally, of course, we talk about the cost effectiveness and the individual predictors of individual response. So, but finally, I would say that it will still be a matter of patient's preference. The decision-making process will have to be carried out with the patients. Perhaps he might prefer an RDN over an escalations of a BP drug therapy. Thank you.
Thanks, wonderful. We are sharp at the hour, 90 minutes. So again, thank you very much, everyone, for your time and participation. Keep safe and good night. Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.